Hello and welcome to the last session of this kidney disease emerging treatments and new approaches. Today we're going to talk about new therapies targeting hypertension with implications for kidney disease. And I am Beatriz Fernandez from Spain, and I've got my pleasure to introduce today to Johannes Stegbauer from the University of Düsseldorf. Professor Stegbauer is a very well-known scientist physician, is a very well-known expert in hypertension, renal angiotensin system, cardiovascular, atherosclerosis, chronic inflammation, and so on. He is a part of EURECAM, a board member of EURECAM, as well as the rest of panelists and myself. And his research has been awarded with numerous prizes and has been participating as principal investigator in several of the multi-center randomized clinical trials. Now, some of them we're going to talk about today. And he's going to give us a very nice overview of new treatments for hypertension and CKD approaches in CKD population. We also have Professor Francesca Mallamaci as panelist today. She is a very well-known chairwoman of the European Renal Association. She is actually EURECAM Working Group chairwoman of the scientific committee, and she's been the scientific committee chairwoman of the last Milan European Congress. That's been very successful. She is chief of department of nephrology, dialysis, and transplantation in Reggio Calabria, and she's also chair of epidemiology and part of physiology and renal diseases of the European Renal Association in Reggio Calabria. And the other panelist, Professor Olga Balafa. She's consultant in nephrology at the University Hospital of Janina, and she is experienced in peritoneal dialysis and cardiovascular disease in chronic kidney disease. She's very well known, specialist in hypertension and CKD. And together we are going to introduce you to this fantastic world of hypertension and chronic kidney disease. So now is my pleasure to introduce Johannes Stegbauer presentation. Professor, ready when you are.
Thanks. Thank you very much for this kind introduction. So these are my disclosures, and I was asked to give a talk about new therapy targeting hypertension implication for kidney disease, but I would like to focus it more on new targets targeting hypertension, and the focus on kidney disease will be shown in a few slides, but I think it's very interesting to know how these new targets are working. And why do we should treat hypertension? Hypertension is one of the most common diseases. More than 1.3 billion individuals with hypertension worldwide, and according most likely to non-knowledge and or non-adherence, but also resistant hypertension, inadequate blood pressure control is about 40 to 60%. And this is a big task because hypertension is still the leading cause for morbidity and mortality. And this is an old but nice single center study where about 1,000 patients with hypertension were followed up by more than 10 years. And as you can see, patients with true resistant hypertension has the lowest survival compared, for example, for patients who respond to their treatment. So for us, it's one of the biggest challenges and tasks to treat hypertension adequately. And it's not only the mortality, it's also the causes for renal failure requiring dialysis. These are data adapted from the US renal data system, and hypertension is number two. It's the second cause for renal failure in the US, but also in Europe. So this is very important. And since last year, we have new hypertension guidelines. And if we will focus on resistant hypertension, and also if we want to see what is different between patients with a CKD stage 1 to 3 compared to stage 4 to 5. The basic blood pressure reducing drugs are similar. We have to choose ACE or ARBs plus calcium canal blockers and diuretics. And then if we have CKD stage 1 to 3, we can add either spironolactone, which is preferred, or another mineralocorticoid receptor antagonist, or a beta blocker, alpha blocker, or a central acting agent. In some centers, in specialized centers, you can also consider renal denervation. If you have stage 4 and 5, our therapy options are limited. It's not only for treating hypertension, but also for a lot of other diseases. We have additionally chlorothalidone, which is the preferred drug, where there was a big or good study showing that chlorothalidone or thiazide diuretics have an effect even in CKD4. We have beta blocker or alpha blocker, or again, central acting agents. And to show you some new therapeutic options, I will focus on endothelin antagonists and aldosterone synthase inhibitors, ASI. And first of all, I would like to show how, or would explain how they work. Then I will give a very short overview about the current situation, focused on hypertension, but especially for the endothelin receptor antagonists, also for kidney disease. And then I will give you some conclusion, why do we need maybe these two drugs? But based on what I said before, I think this is something quite evident. So let's start with endothelin. And this is a picture made end of 1988 in London, and this was the first conference about endothelin 1. And why was it the first conference? Because endothelin was discovered in March 1988 by a Japanese group, and it was described as a very potent vasoconstrictor produced by vascular endothelial cells. And it's a peptide by 21 amino acids. And so far, it's really one of the strongest vasoconstrictors. This was shown in vivo, and also the contraction in coronary arteries. But how does this works? Endothelin is produced in endothelial cells. That's why it got its name from. And then it is released, and it acts on two different receptors, ETA and ETB receptor. If we now focus on the vascular smooth muscle cell, if you focus now on the smooth muscle cell, we have especially a strong vasoconstriction by activating ETA receptors. The ETB receptor is so-called more or less the endogenous antagonist. It is expressed a little bit on smooth muscle cells, but is also expressed on endothelial cells, and if as a reuptake more or less. And if it's activated on endothelial cells, nitric oxide is released, and this causes a dilation. So we have in this system more or less a yin and yang situation. As I showed before, the vasoconstrictor response is mediated by ATA receptors. And in the kidney, and these expression is different in different organs. So if we look at the kidney, we have a very strong distribution of ATA receptors in the renal vein, arteries, and on vascular system. But on the epithelial cells, we have more ETB receptors, and this maybe causes also the side effects. So what is endothelin 1 doing in the kidney? The endothelin 1 is upregulated in CKD, and also if you have high proteinuria by about 4 fourfold. It causes vasoconstriction, as I told you, via ETA receptors and more in the efferent than in the afferent arterioles. We have also expression of ET receptors in podocytes, and this can cause impairment of the slit diaphragm and causes proteinuria. Interestingly, endothelin-1 and angiotensin-2 induces synergistically effects on blood pressure, but also on pro-inflammatory effects in the kidney. And endothelin-1 mediates natriuresis and diuresis mainly via ETB receptors within the collecting duct. And this is not 100% sure how, but there is a close interaction between ENaC expression or inhibition and the vasopressin signaling pathway. So I told you 1988 endothelin was discovered, and only 10 years later, the first paper came out about the effects of an endothelin receptor. It's a dual endothelin receptor antagonist bosentan. We all know that in the treatment of primary pulmonary hypertension, and that has shown that bosentan reduces blood pressure. But unfortunately, as you can see, you need very, very high doses of bosentan to reduce the blood pressure. And unfortunately, because of these very high doses, there are very severe side effects, hepatotoxicity and edema, development of edema. And especially the edema will show up in all other trials I will show you later. And only to compare, if you want to treat primary pulmonary artery hypertension, you need only twice 62.5 milligrams to 125 milligrams, so a much lower dose. And at the end of 2022, so almost a little bit more than 1 year ago, the first trial came out about an dual endothelin antagonist, aprocitentan, for treating resistant hypertension. This was a phase 2 trial. And before I show you the results, I would like to give you more details about aprocitentan. Aprocitentan has a half-life, a very long half-life, about 44 hours. It's a dual endothelin receptor antagonist with a higher affinity for ETA than for ETB receptors. And this is something very important. It's not metabolized by some CYPs. And there's no influence of gender, race, age, body fat, and renal function on plasma levels. So that's quite interesting and important. Interestingly, we know that if we treat patients with dual endothelin receptor antagonists, the concentrations dose-dependently increases of endothelin-1. And based on animal data, preclinical data, there might be a synergistic effect of endothelin receptor antagonists, in this case aprocitentan, and blockers of the renin-angiotensin system. So this is the effect in, that was, I think, rats. Spontaneous hypertensive rats only for the ARB. This is endothelin, and this is a combination of both. So there might be a synergistically effect. So back to the study. The study was quite clever designed. There was a screening visit, and then after, back standard, all patients should be, or they had to be treatment resistant, and they got a standardized medication of an ARB, a calcium canal channel blocker, and a diuretic. And then there was a placebo run-in phase. And because we participate in the study, and the adherence was tested, and it was allowed to tell the individuals, the participants, to say, hey, there might be something wrong with your tablet intake, and so we always test the adherence, and then then there was the randomization, and there were 3 different a path, a higher dose of aprocitentan, a lower dose, and placebo for 4 weeks. Then a single blinded phase where all patients got aprocitentan 25 milligrams, and then again the double blind phase for 12 weeks where the effect of aprocitentan in the higher dose was compared to placebo. The study population was well balanced, and we have about 25% of participants with a CKD 3 and 4, and also with a about almost 50% with a proteinuria A2 and A3. So we can say, based on this trial, also something about how aprocitentan reacts in patients with more severe kidney disease. So what were the results? And I want to focus on this here, on this big blood pressure drop after randomization, and that was where the patients so I think this blood pressure drop was adherence, because then they were told, hey, you should take your medicines. So even in the placebo group, the blood pressure dropped by more than 10 millimeter mercury, but there was a significantly bigger decrease in blood pressure in the individuals with aprocitentan, and so this was a significant difference. Aprocitentan reduces blood pressure even more, and in the single-blinded phase, there was this blood pressure drop remained, and then in the third phase, where it was again double-blinded and a withdraw, we could also see back this difference of about 10 millimeter mercury blood pressure difference. And this is shown for this first phase more nicely. So you have in both doses a significantly reduction compared to the placebo in a 24-hour ambulatory blood pressure measurement. And if you show this, it's lasts both daytime and nighttime, about 8 to 10 millimeter mercury. And this is a very huge reduction in patients with resistant hypertension. If you look at subgroup analysis, so the blood pressure effect is similar in all subgroups in age, does not differ whether you have no or high proteinuria, and even if you have no, and it looks like that you have a little bit better effect in patients with decreased or with CKD, but this has to be proven in bigger trials. And again, if we look at the albuminuria creatinine ratio, aprocitentan showed a decrease in all phases of the albuminuria creatinine ratio compared to placebo. So it looks like that even in patients with resistant hypertension, the treatment with an ET or with aprocitentan reduces albuminuria. What about the side effects? And I told you in the first study with bosentan, there was a lot of edema. And again, here we have also edema and fluid retention. And this was significantly higher compared to placebo, and it was dose dependent. And based on the protocol, if the individuals or participants developed edema, you can use additionally diuretics, and this was more used in the higher dose. In the single phase, we saw also this the same percentage, about 18% develop edema, and so this is something you really have to take care of. And other trials with ET receptor antagonists showed also an increase in heart failure. This was not shown. And the hospitalization for heart failure was not significant different compared to placebo, but there might be a small signal based on this fluid retention. So this is something you really have to keep in your mind. So where to put maybe endothelial receptor antagonist in the treatment of resistant hypertension and in the context of chronic kidney disease. And maybe this could be a new option and a very potent option in patients with CKD stage 4 and maybe 5, because it is not the plasma levels are not um, modified by the kidney function. So this could be a good option. Okay. There are two other very new studies investigating the role of an endothelial receptor antagonist in kidney disease, and this was sparsentan, and it was compared to irbesartan. And why irbesartan? Because sparsentan is a dual endothelin receptor and angiotensin receptor, angiotensin 1 receptor antagonist. I told you there might be synergistically effects between endothelin receptors and angiotensin 2 type 1 receptors, and that's why they combined both. And there's a 50-fold higher selectivity for ETA and ET1 compared to ETB and ET2 receptors. And in this trial, they investigated more than 300 patients with focal segmental sclerosis. And as you can see here, in patients who were treated with a dual endothelin receptor and angiotensin receptor antagonist have a higher decrease in urinary protein to creatinine ratio compared to only the ARB. And also the complete remission was higher in these patients. So this was something very encouraging, and other studies are following to investigate this the effect on focal segmental glomerulosclerosis. And interestingly, the study they found no differences in side effects between sparsentan and irbesartan. Another study, which was published 2 months ago, looked at the efficacy and safety of sparsentan versus irbesartan in EGA nephropathy. And also there was a significantly better outcome for patients who receive the dual endothelin receptor and AT1 receptor antagonist compared to only irbesartan in terms of the renal endpoint. And this was 40% decline in GFR, dialysis, or death. And also the change in GFR from baseline was better in was different in the group between sparsentan and irbesartan. Okay, so now I'm coming to the second part, and this is about aldosterone and aldosterone synthase inhibition. And this shows a group in 1953, and they celebrating the investigation of aldosterone. At that time, it was called electrocortin, and we know aldosterone for a long, long time. But still, there's a lot of things we can learn, and I think the studies on phenylneurone showed us more potential in CKD, but I don't want to focus on that. I want to focus on aldosterone synthase inhibition. What is aldosterone doing in the cardiovascular system? It plays a big role in hyperaldosteronism. We know that higher levels of aldosterone levels are associated with the development of hypertension, and I show you some data later. It plays a big role in resistant hypertension. There is an aldosterone escape during ACE inhibition and or ARB therapy, and aldosterone is a mediator of organ damage. So if we use spironolactone, which is a very potent treatment option for hypertension, we are always have this problem of gynecomastia, and this is dose dependent. And I mean, normally I don't use these high doses, but if you use doses between 150 to 300 milligrams per day, then 50% are suffering from gynecomastia. And in the RAILS trial, this is famous trial for heart failure, about 10% had this side effect. So there is a need for other treatment options. And the problem, a long time to develop a good aldosterone synthase inhibitor was that that there are two CYPs which are metabolizing cortisol either to cholesterol either to cortisol or aldosterone, and one is the CYP11B1 and the other one is the CYP11B2, and these two CYPs share about 93%. They are similar in 93%, and that's why it was so or is so difficult to develop a selective target only to inhibit CYP2. And finally, this was successful done, for example, here for baxdrostat. There are now other also selective aldosterone synthase inhibitors, but this is now manageable. And interestingly, CYP11B2 does not is synthesizing cholesterol to aldosterone not only in one step, in 3 steps. And so that means that if you block this pathway, you will increase these metabolites which were in front of at the beginning of this pathway more than aldosterone. And this was done in a first study already 7 years ago. These metabolites were measured, and as I told you, under the CYP11B2 inhibition by baxdrostat, there's an increase of 11-deoxycorticosterone, which is at the beginning of this pathway, and a decrease of all other metabolites, and especially aldosterone, which is the latest, which is the last metabolite, which is metabolized of aldosterone. And the selectivity for CYP2 is very high compared to the to CYP1, and this was then shown if you measure cortisol levels, which remain stable in a dose-dependent manner compared, for example, this 11-desoxycortisol, which increases dose dependently. Okay, so what are the effects of baxdrostat on treatment-resistant hypertension? And this was a small phase 2 trial published a year or almost a year ago. This trial was a randomized double-blind placebo-controlled multicenter trial. It was not a long trial, about 12 weeks of a double-blind treatment period, and the exclusion criteria was compared also to other mineral corticoreceptor antagonists, a glomerular filtration rate smaller than 45 milliliter per minute per body surface. And there were 3 different doses, and the blood pressure response was tested, and also the chemical parameters. Again, if we look at the urinary aldosterone excretion, placebo is doing nothing, and the aldosterone excretion as a marker for aldosterone production is significantly reduced if you inhibit the aldosterone synthase. Also, the aldosterone levels in the serum are significantly reduced. In the highest dose, based on this negative feedback mechanism, in the highest dose, we see a small increase in renin activity, which we always see if we use ACE or ARBs. And again, no influence on cortisol levels. So what was the effect of the ASI on blood pressure in therapy resistant hypertension? Again, in the placebo group, we always see this effect on blood pressure. In my opinion, it's based on adherence in these trials. And what we see, especially in the group where the individuals receive 1 milligram or 2 milligram, there was a significantly higher decrease in blood pressure in office blood pressure compared to placebo, and that was about 20 millimeter from baseline, and compared to placebo, we have about more than 10 millimeters. So it was effective. But we always also see these effects on hyperkalemia, and this was defined as hyperkalemia more than 5.5 millimole per liter, and we had 5% with participants with hyperkalemia in the group with receiving 1 or 2 milligrams per day. Another study with lorundrostat showed similar results, and that was also published more or less at the same time. So this might be might be a new option, especially without the side effect of gynecomastia or other effects on the steroid pathway. So it could be a new option for the treatment of resistant hypertension in patients with CKD 1 to 3. But I also want to show that because it's based, except of this hyperkalemia, it's very well tolerated. It could be maybe a treatment option for primary hypertension. And this is something I want to explain based on data from the Framingham study. In that study, in the sub-study, it was shown that these 1,688 patients were divided in quartiles based on their aldosterone levels, and then they were followed up. And all these patients did not, at the beginning of the study, had no hypertension. And then the patients who were followed up for 4 years, and the group with the highest percentile with the highest aldosterone levels had the highest percentage for an increase in blood pressure, but also for developing hypertension. So even in patients who were at the beginning or had primary hypertension, or where hypertension was not treated, aldosterone seems to play a role. And another study from the has shown that the resistant hypertension, but also normotensive hypertensive stage 1 and stage 2, had a high percentage of patients with an more or an increased aldosterone release measured by aldosterone 24-hour urine measurements. So again, here it might be feasible to think that aldosterone, not only for resistant hypertension, but also for other forms of hypertension, primary hypertension, might be a new option. So I would like to sum up. I hope I could show you how endothelin receptor antagonists and aldosterone synthase inhibitors work. Endothelin has the strongest endogenous, is one of the strongest endogenous vasoconstrictor by and if you by mediating or by activating ATA receptors. Aldosterone synthase inhibitors are effective to inhibit the aldosterone production without influencing cortisol levels. The current study situation is manageable today. So we know that there is a dose-response relationship proven for both substances. With reasonable side effects. For ET receptor antagonists, it's the edema, and for AZ is the hyperkalemia, but we have no hard endpoint so far. And why do we need ET antagonists and AZ at all? I think they could be very new or good alternatives for treating resistant hypertension, but also it could be especially or both a good option to treat CKD and hypertension. I mean, hypertension is very prevalent in CKD. It has a nephroprotection, and especially for AZ, there might be a possible treatment of hypertension in earlier stage. And now I'm finished, and hope I could show you new data about these two antihypertensives. Thanks.
Thanks, Professor Stegbauer. Now, thank you. That's been great. And I would like to open the discussion with our panelists. We'll give Professor Stegbauer a couple of minutes and I would love to have a word on Professor Mallamaci about this. It's like, where do we see this CKD population? So CKD population, it's been like there's a large unmet needs in our patients. So as you've seen, as Johannes seen before, there's been like, it's a difference if you are stage 1 to stage 3 or if you are stage 4, stage 5. And that's a different way of thinking. That's a different way of treating the patients. So you were talking about endothelin receptor antagonists for patients with lower eGFR, regarding that you can give them with eGFR below 30-45 milliliters per minute, and it will be good. And what do you think about these new evidences in SGLT2 inhibitors? Do you believe that if we give SGLT2 inhibitors plus endothelin receptor antagonists, we can avoid or overcome these problems of ETB activation, and we can overcome this with using SGLT2 inhibitors for increasing natriuresis? We can achieve better results with endothelin receptor antagonists?
Well, I think you were asking me something, Beatriz. So I think that we shouldn't forget the salt. When we speak, we discuss about this very, very encouraging new drugs, like the the drugs that Professor Stegbauer discussed about. But we shouldn't forget salt, because we are aware that the sodium and the volume excess are the fundamental risk factors for hypertension in chronic kidney disease. And we also know that the chronic kidney disease patients are salt sensitive. And sodium retention and the volume overload are strictly related to kidney dysfunction. In addition to medication, lifestyle interventions are very important. And so limiting the salt in the diet, like is recommended that salt should be less than 2 grams daily. And another lifestyle intervention is fighting the sedentarism, that is to recommend, in other words, physical activity at least 150 minutes per week to the hypertensive patients in general. So we need these new drugs. And I think we have also evidence that these new drugs, such as the ACE inhibitors and the drugs that the endothelin inhibitors work better. There are strong evidences that work better when the patient is in a low salt diet. Another thing is why diuretics are so important in CKD, in hypertensive CKD patients. We know that the diuretic constitutes the cornerstone of blood pressure control in chronic kidney disease patients, because, as I said, patients are salt sensitive. They have a salt sensitive hypertension. And very recently, the clortalidone was came out as a very good diuretic, even in patients with CKD4. And we all know that at least in earlier ages, the diuretics that were recommended in this from stage 4 and on were furosemide and the loop diuretics. But now there are very good evidences that clortalidone is very effective in controlling also resistant hypertension in CKD patients. I want to add another thing, and I asked Johannes why he didn't mention at all finerenone. We know that finerenone is another anti-aldosterone drug that is very good. There were a lot of very good papers about that. The Fidelio and the Fidero showed that the finerenone can decrease the also albuminuria in CKD patients and improve the outcome, the renal outcome. So I think that also finerenone is a very good promise for this kind of patients. So just to summarize, because also what Johannes presented was very complete, and we have not so much time, I could synthesize saying that the volume expansion is pervasive in hypertensive patients with CKD, that the low salt diet is a must in the treatment of high blood pressure in CKD patients. Diuretics are of paramount importance in the treatment of this kind of patients, clortalidone, a long-acting thiazide-like diuretic, may be useful even among people with advanced CKD for improving hypertension control. But I have to conclude saying that well-powered randomized trials assessing hard outcomes are still necessary to more confidently recommend the use of these drugs in advanced CKD. I think that the presentation was so complete that we can just stop here. At least I can stop here.
Thank you very much, Professor. So talking about this mineral receptor antagonist, we've got some questions about aldosterone synthase inhibitors and mineral receptor antagonists. And there are some questions about secondary primary hyperaldosteronism. And do you think that baxdrostat will be able to avoid adrenalectomy in patients with primary hyperaldosteronism that will get better?
Shall I? Okay. So it again. So if these patients have bilateral adrenal hyperplasia, then this will a treatment option. But if they have an adenoma, I would say that depending on the choice of the patient, I would still prefer the adrenalectomy or the because the outcome is looking a little bit better for the operation compared, if it's possible, compared to treatment. But for bilateral hyperplasia, the synthase inhibitor is an option, yes. And there it came up about the non-sterile mineral corticoid receptor antagonist, finerenone. I mean, it showed very, very good effects on the primary endpoint of reducing the decline in renal function and also for heart failure, but it was made that the blood pressure effect was not so strong, about 2 to 3 millimeter mercury. But there are other, especially Japanese studies showing that non-steroidal mineral corticoid receptor antagonists show also a very good blood pressure response. So I think that in a few, and there are ongoing studies, that in a few years we will also see good data with non-steroidal mineral corticoid receptor antagonists on blood pressure reduction. It's only a matter how these drugs were designed and how they then show a blood pressure reduction or not. And maybe these had a lower incidence of hyperkalemia, but I don't know. I don't know.
Thank you. And do you think, Olga, that will change the regular clinical practice and that will change the guidelines? Because nowadays we've got like different guidelines and everyone says different things and different targets. But do you think the addition of endothelin receptor antagonists or the ACEs or new mineral receptor antagonists that Professor Mallamaci said before will change the clinical practice, and this change of clinical practice will eventually change the current guidelines?
I'm not sure, unfortunately, because I don't know whether the companies will take so much money to only to conduct a hypertension trial. At the moment, it looks more that they, which is good, they look on trials where you combine, as you mentioned, SGLT2 with, for example, then an endothelin receptor antagonist to treat chronic kidney disease, and then there might be also an effect on blood pressure, and then it will be a big debate. What is the cause? Is it also the blood pressure reduction, etc., etc.? And as far as we do not have good endpoint studies, it will be very difficult to change treatment recommendations only for the blood pressure. I think we will come then in a scenario where if you have high blood pressure and kidney disease and albuminuria, you should choose this then as a therapeutic option. So it will be more complicated and more personal based, I would say.
Professor Balafa, what do you think? Do you agree?
Johannes, thank you for your presentation. It was really, really very nice. And thank you for answering my question. Well, I think it's still very, very early. Of course, there is a fascinating era in front of us. New medication in resistant hypertension, new medication in CKD. We don't know. We need more trials. But thank you, Professor Mallamaci, for reminding us of the fundamental standard of care therapy in CKD patients. As we're moving forward to new therapies, we should never forget the fundamental salt restriction and compliance to all of the available medication. Professor Stegbauer mentioned that in the placebo arm of all of the resistant hypertension trials, there is a reduction of systolic blood pressure, a reduction up to 5 or 6. That's not something that we shouldn't pay attention to. That tells us that our patients are not compliant. And when they participate in the trial, they take their medication and we have a decrease in the systolic blood pressure. So yes, we should begin with salt restriction, giving all the maximum dose of our available medication and try to convince our patients every day to stick to their therapy. Secondly, I think that it's really fascinating that apart from blood pressure control, all this new medication, both of them have a very good favorable effect on albuminuria. 2 weeks ago in Lancet, there was a publication study comparing aldosterone synthase inhibitor with dapagliflozin, with empagliflozin. And there was a reduction in albuminuria. It was a short study, 3 months, and a reduction in systolic blood pressure, 5 to 8 mmHg in the groups. So yes, we have more to see in the next years, in the next months.
And that's very important because it's like what Professor Mallamaci said. We are moving forward, things are going very fast, but sometimes clinicians, we forget like the fundamental treatment, and sometimes we forget to ask the patient. Professor Mallamaci, I warn you.
Sorry, I wanted to add something else. When we have new drugs, we are really very happy to have new drugs. And I must say that very recently, nephrologists have good drugs, and we can work very well. But we have to remind everybody that resistant hypertension in our hands, I mean, in the hands of nephrologists, is in a minority of patients, because we use all the drugs that we have very well and according to the GFR. Another thing that I want to add is I'm really always keen on reminding people that sleep apnea is the main cause of resistant hypertension, and we have to keep in mind that sleep apnea now can be corrected with very small devices. So it's good to remember it. And finally, I would say if we are not able to control hypertension, we have renal denervation, and very recently, Schmider published a very good reviews about renal denervation, because with the new devices, this procedure, when it's really needed, is very good. It's very promising.
Thank you very much, Professor. That's a very good point, the renal denervation. We've got some questions about this renal denervation, as if you did before renal denervation, before starting another drug, which is like aldosterone synthase inhibitor or the endothelin receptor antagonist or whatever. Could you go before giving more medications, more drugs? Because sometimes it's like a matter, as you said before, a matter of non-compliance of the medications, because more and more medications doesn't mean that this patient's going to take them. So what do you think about that? Do you think it's better to start thinking of more medications, or do you think it's better to perform a renal denervation on the light of new results?
Are you asking me? Well, I think that renal denervation should be the very last, how you say, the very last resource that we should use. I'm not with I don't agree with our American colleagues who ask patients, do you want to just to be denervated or taking pills all your life? I don't agree. So it's the last resource that we have to take in mind.
Do you have any different opinion, Professor Balafa, Professor Stegbauer, about this renal denervation?
I agree with Professor Mallamaci. We don't have data in CKD4. We don't have data in lower GFRs, and it's going to be a perfect solution, but for a very small proportion of patients, and these patients should be very, very well collected. It's not for everybody. It's not something that I would choose easily for my patients.
Professor Stegbauer?
I think it's all about adherence. So if we have to make sure that the patients, and we have to train the patients that they will take their blood pressure medications. And if this is somehow not possible, then this option should be considered. And as you mentioned, the number of antihypertensive agents also influences adherence. Lower have a better adherence than more. So we have to find a way in between when to suggest or talk about renal denervation in these patients, especially if they are taking more than 4 antihypertensive drugs. And what happens if they say if the adherence is low? So what are you doing then? You say it's bad luck, or you say, okay, there's another option where you might reduce blood pressure by about 8 millimeter mercury without taking blood pressure, taking pills. Again, it's a very difficult question. It shouldn't be used without a good balance, without testing adherence, without training. But if then it's again also a mix of patient and doctor decision.
Okay, thank you very much. I think we've reached the end of our session for today. And I would only want to thank everybody, thank our panelists, thank our speaker. And like a closing remark, I think it's train your patients, be sure they take their pills, go to the fundamental treatments, but know that if everything's not working, you still have new medications ongoing that you can use, and new devices ongoing that you can think of them to enhance the control of your patients' CKD and non-CKD population with hypertension. Thank you very much for being here today.